This week on the BackTable podcast.
That component of there might already be permanent damage is so critical.
Yeah, it's funny that you say that conversation that so many of us have had, and that's actually part of the history of priapism, is that when priapism was first reported in the literature in the 1800s and 1900s, the initial thinking was that surgical interventions should actually not be pursued because they found that these patients who had priapism we're looking at 2 weeks plus, that after they tried the leeches and the injections and all these other homeopathic things, and they finally said, well, let's try a surgical maneuver to try and drain this blood. And they said, oh my gosh, I did surgery on this guy. It's been 16 days. He's lost complete erectile function. Surgery must not work. We should not do surgery.
Hello, everyone, and welcome to BackTable Urology. I'm Dr. Juan Andino. I'm a urologist with a focus on sexual medicine and male infertility, and I get to be today's guest host. And we have Dr. Maia VanDyke from UT Southwestern, one of my colleagues with a GERS lens and a GERS background, and we're going to be talking about priapism. Dr. VanDyke, can you tell the audience a little bit about yourself?
Yeah, absolutely. Juan, thanks so much for the warm welcome. I'm really excited to be here as we talk about this today. So, I am a reconstructive urologist in Dallas. I did all of my training at UT Southwestern, including, as you mentioned, a GERS fellowship under Al Morey and Steve Hudak, and was lucky enough to get to stay on as faculty after I finished my training a couple years ago. So here I am, excited to be here.
That's fantastic. And we share some parallels, which is why today's going to be so fun, is a topic we're both passionate about. For our listeners, we nerded out about this after our oral boards at dinner. Instead of talking about, after talking about life and family, we started talking about priapism and penoscrotal decompression. So getting to do it here at BackTable for people to tune in is quite a pleasure. Let's get started.
Let's do it.
So first, let's set the stage. Priapism, everybody remembers it from residency. You get that page or that phone call, and there's always an immediate feeling of terror. So for our talk today, before we dive into the nuance and some of the details about penoscrotal decompression, give the listeners a little bit of info on priapism itself, the acuteness of the condition, and kind of the starting place of how we should approach this discussion.
So the very first thing to remember is that there are two different kinds of priapism, right? There's acute ischemic priapism, which makes up 90 to 95% of priapism cases, and then non-ischemic or high-flow priapism. And what we're going to be focusing on today is ischemic priapism. That's a urologic emergency, and it's a form of end organ compartment syndrome, right? So what happens is normally when you get an erection, the smooth muscles in the penis relax. That allows blood to flow in. It occludes the venous outflow. And then when it's time to be done with that erection, it all reverses. The smooth muscle contracts, the blood flows out, the erection goes away. And when that mechanism is disrupted, then that blood is not able to flow out of the penis. You get ischemia, hypoxia, acidosis. And if that continues for more than 4 hours, then we call it ischemic priapism. And if it's not attended to urgently, emergently, then you end up with long-term issues. That ischemia leads to corporal fibrosis, leads to erectile dysfunction, and then you have problems.
Yeah, that's so critical, that urgency and emergency component. And are there certain patient populations where this is more of a red flag, something that we need to be, thinking about or considering?
Yeah, so the most common patient that's affected by priapism is a man in his 30s and 40s. Okay, we know that from numerous studies. There are various things that can contribute to priapism, everything from injection of vasoactive agents like ICI for erectile dysfunction, whether it's prescribed or not prescribed. I think you and I are probably going to touch on that here in a little bit. Various medications. We always think about trazodone, right? Trazobone from when you were a medical student or a resident, but various other medications, beta blockers, antidepressants can all contribute to this. And then from a population standpoint, we know that sickle cell patients, specifically patients with sickle cell disease, have a much higher incidence of ischemic priapism. Somewhere between 30 to 40% of patients who have sickle cell disease will have at least one event of ischemic priapism over the course of their lives.
Yeah, that's so critical. And, one of the things that we learned recently doing a study on our almost 9 years of priapism cases at UCLA was ultimately published in the International Journal of Impotence Research, but it was almost 200 patients. And, we always think about sickle cell, we always think about trazodone, but one of the things that stood out to our team and the awesome med students that led this effort was that there were a high number of antipsychotic medications on that list. And quetiapine actually was one of the ones that we saw most commonly after intracavernosal injections or trazodone. And I think one of the, not necessarily a condition or a diagnosis, but patients with psychiatric disease, with those psychiatric comorbidities, may have some sociodemographic issues that could play a role, but also the medications used to treat different psychiatric conditions may actually increase the risk of priapism, especially if they have alpha adrenergic activity.
You're absolutely right. I was just on call at our county hospital last weekend, and we had a patient who had been on trazodone, had an episode of priapism, had to come into the emergency room, had to get aspirated, had to have injections. He went back to his psych provider, changed his medication. What did they change it to? Seroquel. And then he came in a month later with the same picture. So you're right. So many of these medications are so important, right? Mental health is a big problem in this country and around the world. And it's not like we don't want people to get treated for this, but we do have to keep these medications in mind when patients present.
Yeah, that's so true. I think it's something that even from the urology side, we don't think about. And so we're trying to brainstorm what are ways to kind of disseminate this type of information. So very similar thing. A few months ago, we had a patient that had now been to 3 or 4 different hospitals, bouncing in and out with recurrent episodes of ischemic priapism. And we looked at the med list and same thing. We saw, Seroquel, trazodone, multiple agents that were risk factors. And finally, we had been able to kind of make contact with the outpatient side of his care and highlighted some of these agents, and they were able to make switches and changes. And now, knock on wood, but he hasn't been in the hospital or the emergency department since.
Yeah. And I think that really highlights the fact that, this is a urology emergency, but it does require some of that multidisciplinary care and attention, not just to the penis, right, but to the rest of the patient, medications, other things that may be overlaying the condition.
Yeah, that's excellent. And so now we've heard a little bit about kind of the background, epidemiology, maybe demographics that play a role. Let's touch upon the AUA guidelines a little bit. So patient comes in, we're worried about ischemic priapism. What does a urologist in the community, what does a resident or fellow need to do to confirm that diagnosis and get the appropriate therapy started?
Yeah, so just like when you and I were prepping for boards, right? We want to get a history, look for some of these inciting factors. And then we also want a physical exam, right? So you're looking at the penis. Is it rigid? Is the glans rigid as well? It should not be in ischemic priapism. And you really want to differentiate between that ischemic and non-ischemic priapism. There are various tests that you can do to distinguish between the two. Corporal blood gas should be your go-to. So there's 3 things that a corporal blood gas can look like, right? It can look like normal venous blood. That's what it should look like. It can look ischemic, or it can look like arterial blood. And so you need to differentiate between those 3 when a patient comes in. Other things can also be added in there, things like penile duplex ultrasound, looking for cavernosal blood flow. So if there's ischemic priapism, there should be little to no arterial blood flow in the cavernosal arteries. And then some people, especially, David Ralph talks about this a lot, the question of using MRI, especially in the prolonged ischemic priapism setting. Now, not typically to make that initial diagnosis, but more long-term for patient counseling and trying to get a sense of long-term effects on erectile function and things like that.
Yeah, we'll touch upon that a little bit later, but that counseling piece becomes such a critical part of this entire process when things progress. So now let's assume we have a patient, we have the diagnosis, corporal blood gas is consistent with ischemia. What is the first line intervention to try to address this? And typically that patient is still in the emergency department, for instance.
Yeah, so we look at things like aspiration, irrigation, an injection of sympathomimetic agents. So phenylephrine is the most common one that we use. So I think my key takeaways to any medical students or residents here, or people who just don't deal with priapism a lot, is that your goal is to reduce the pressure in the corpora cavernosa. And the easiest way to do that is to put a large bore needle in the corpora at 9 3 is usually what I recommend doing. Stay well away from the urethra and stay well away from the dorsal nerves. And then I attach that 18 gauge needle not to a 50 cc syringe, but to a 10 cc syringe, because it's much easier to aspirate that ischemic coagulum with a big needle and a small syringe than a small needle and a big syringe. So you want to decompress the corpora as much as possible. You can try irrigating with injectable saline. There's some data that suggests that in patients without sickle cell disease, that colder irrigant can be more effective than room temperature or warm irrigant, but you don't want to do that in sickle cell patients, because you think about that graph of the sickle cell. What you don't want is to inject cold fluid in those patients. And then we think about injection of vasoactive agents, things like phenylephrine. So generally this is pre-mixed. You can get it from pharmacy. We're generally talking about 100 mics per mil. And you can do all of this stuff at the same time. But just remember the risks of hypertension, bradycardia. You want all these patients to be on a monitor, and you need to make sure that they're not on things like MAOIs.
Yeah, that's so critical. Those are really some of the high points and things to keep in mind for that early management. And I think another potential benefit of using that 10 cc syringe is that sometimes there's a temptation of wanting to reduce the pressure. So let's drain a lot of blood from this man's body through the corpora. And that's not necessarily going to be that beneficial. In fact, there was a great lecture on priapism by Dr. Tom Liu. I think it was one of the COVID series lectures where he talks about, maybe it's closer to 75 or 100 cc's that you can aspirate or remove from the corpora first, try to promote some oxygenated blood to come in there, and then provide the phenylephrine to have a better effect in the corpora. But you don't necessarily have to pull out, 10 50 cc syringes and see that hemoglobin drop when you get the follow-up labs.
Yeah, absolutely. And to that point, you're not just reducing the pressure to get the blood out of there, but you want to relieve the pressure on the venous drainage system. And it doesn't take that much aspiration to get a little bit of relief. And between that, the irrigation and the phenylephrine, you're right, you're going to get some more of that oxygenated blood in there, and you can get some more outflow through those normal pathways.
Excellent. And now we've done the diagnosis, we've done the first steps. They've had phenylephrine, aspiration, irrigation, a combination, sometimes multiple rounds, hoping that we don't have to progress to the more invasive treatment options. Are there things that you're sharing with patients throughout this process, especially if, let's say, they've had a priapism for 20 hours, 24 hours, it's lasting a little longer?
Yeah, absolutely. So I think that the importance of early counseling cannot be overstated, because these patients, we know that fibrosis can start setting in somewhere around that 6 to 8 hour time frame. And some of these guys, especially the ones who borrowed the ICI from their friends and over-injected it, they're embarrassed, they don't want to come in, they don't show up until it's been 24, 36 hours or more. Going back to this study from Mulhall, where they looked specifically at sickle cell patients, but this applies to all patients, that patients who have a priapism lasting more than 24 hours have a much, much higher chance of long-term erectile dysfunction, anywhere from 85 to 90% of these patients. So I know you and I have talked about this offline as well, but that early counseling, talking about how my goals are to relieve pain, relieve the priapism, and preserve erectile function as able. But to start talking about the fact that they may be looking at long-term erectile dysfunction, which is a hard conversation to have.
It is, but I think saying it out loud, repeating it multiple times, hearing at different stages, and then documenting it, of course, in the electronic medical record. I'm sure you've seen these folks as well, but I've had people here, referred to UCLA, and they came in and their, opening statement was, I'm going to sue this doctor in Las Vegas who did a distal shunt. And I was like, whoa, what happened? He's like, well, after the surgery, now I can't get any erections. And it's just very clear that overwhelmed, they're in pain, needles are going into the penis, there's a lot going on. And so it's just reiterating that information that there's already likely damage taking place. We are intervening and hoping to reduce the long-term effects, mitigate the long-term effects, but that component of there might already be permanent damage is so critical.
Yeah, it's funny that you say that conversation that so many of us have had, and that's actually part of the history of priapism, is that when priapism was first reported in the literature in the 1800s and 1900s, the initial thinking was that surgical interventions should actually not be pursued because they found that these patients who had priapism we're looking at 2 weeks plus, that after they tried the leeches and the injections and all these other homeopathic things, and they finally said, well, let's try a surgical maneuver to try and drain this blood. And they said, oh my gosh, I did surgery on this guy. It's been 16 days. He's lost complete erectile function. Surgery must not work. We should not do surgery. And it actually wasn't until the late 20th century with the younger Frank Hinman who really started to turn that story around and said, well, actually, maybe we need to be doing surgery earlier in order to relieve the compartment syndrome and preserve erectile function.
That's fascinating. That historical context, I actually wasn't aware of that. So that's really good to know how medicine changes, and you kind of have to fight against dogma and evaluate new ways of doing things to see if we can improve care for our patients.
Yeah, absolutely. I would not recommend leeches. Not a lot of data to support that.
Yeah, they're not in the guidelines. Now that we've been talking about some of the potential next steps, first-line therapies have failed. We're really starting to think about surgery. Let's talk sticking to the AUA guidelines first. What would be the next step in the AUA guidelines? And then after that, the rest of our chat, we're going to focus on penoscrotal decompression.
Yeah, so the AUA guidelines say that for a patient who has not responded to non-surgical methods, that the next step should be a distal shunt with or without corporal tunneling. Now, this is something that was first described back in, I think, 2014 was the initial description by Bud Burnett of the corporal tunneling. When we talk about basic distal shunts, I think most commonly, most of us do a T-shunt, right? You also think about things like the Ebehoge shunt, the Winter shunt, right? The one with the true cut biopsy needle, or the Algarab, which is a little bit more surgically invasive, right? An actual cut through the glands with a resection of the tips of the corpora. Those are the ones that we've done now for decades. But Bud Burnett first described, I believe in 2014, when that was not enough in the operating room, passing a dilator proximally through those corporotomies in order to release that ischemic coagulum to get a better disruption of all of that ischemic blood and restore the blood flow to the penis. And he found that especially in patients who had prolonged ischemic priapism, that was more effective than the distal shunt alone. So that's what the guidelines say our options are. And those are good options, especially for patients who have had ischemic priapism of 24, 36 hours or less. We know that they work. We know that they work well. And we know that for patients who have good erectile function going into the priapism event and that are present in a good amount of time, right? More closer to 4 hours rather than 48 hours, that they have a very good chance of sexual function preservation and recovery.
Yep, that's so critical. And, I think the last thing to mention before focusing in on PSD is that the commentary in the updated priapism guidelines about the role of proximal shunts. And it's a very nice statement, but it really just highlights, we need to tell patients that there's inadequate evidence to quantify the benefit of doing a proximal shunt when they've continued to have a persistent priapism after distal shunting. And so I think there's certainly folks who are going to have that personal experience that they had good results, it allowed to relieve the priapism. But if we're not only thinking about the acute episode, but also the long-term recovery, it doesn't seem that the evidence is as suggestive that proximal shunts would be a follow-up step to distal shunt and certainly distal shunt and tunneling.
Yeah, agreed. So when I was a fellow, we actually did a survey study with Al Mori where we did a multi-institutional survey of subspecialty surgeons GURS, SMSNA, ISSM. So these are really people who deal with men's health, prosthetics, erectile dysfunction day in, day out. And we ask them what their preferred management is for acute ischemic priapism, 24 hours or less, greater than 24 hours, things like that, okay? And the 1% of respondents even mentioned that they did any proximal shunts at all. And I thought that was great because that's very reflective of what our updated guidelines say. So good on us. We're doing guideline-based care, right? Stick to the things that work and stick to the guidelines. I think they're very well written for this.
Yeah, and that ties it perfectly to then what next? Why are we even talking about penoscrotal decompression? The guidelines are giving us some direction. Why deviate? So what are some reasons that you offer this to patients? What do you share with them as a reason for going down the penoscrotal decompression route rather than a distal shunt with or without tunneling?
Yeah, so I'm going to take a step back. I'm going to talk a little bit about what penoscrotal decompression is, the history behind it, and then walk into it. So penoscrotal decompression is the brainchild of Al Mori, who found when he was treating acute priapism, he would take patients to the operating room with the plan of putting in an upfront prosthesis, right? And he does all of his prosthetics through a penoscrotal approach. And what he found is that when he made the corporotomies, of course, that ischemic crankcase oil blood comes out. And lo and behold, this bright red, beautifully oxygenated blood comes out through the corporotomies once you've passed your dilators. And he said, well, do I even need to place an implant, right? Or is it the act of the corporotomy, the relief of the compartment syndrome, the removal of all of that ischemic old clotted blood, and the refreshing bright red blood coming out of the corporotomies, has that done my job for me? And so this was his brainchild. He tried it. He published on it first with Jocelyn Fuchs when she was a fellow. And what he found was that this is highly effective. 80 to 100% of patients who undergo penoscrotal decompression, even with prolonged priapism, patients who are coming in at 48, even 72 hours, if they're in acute pain, that disrupting this coagulum, relieving the compartment syndrome, can still result in that beautiful bright red blood coming in. And in the follow-up paper that he did when I was a resident, he looked a little bit closer, not just at higher numbers, this is a multi-institutional study with subspecialty urologists and general urologists around the country, but looked a little bit more at the erectile function side of things, and found that not only does it do well at treating the ischemic priapism event, but that there is a suggestion that there's a greater chance of erectile function recovery. So in that paper, while it's relatively small numbers, only 15 patients had documented IE5s at follow-up, about 60% of patients reported being able to get an erection firm enough for penetration. And these are patients that had been up for more than 48 hours. And that's remarkable, right? That's not what we think of when we think about priapism. We generally think anything over 24 hours, I'm sorry, man, the chances of you having meaningful erectile function recovery are low. And so that's the environment in which I trained and is something that I've brought forward to my practice. Now, I don't think penoscrotal decompression should be offered to a patient who's had less than 24 hours of ischemic priapism, because I think their chances are high that a distal shunt with or without tunneling are going to work well. But once you get into that 36, 48-hour time frame, if we don't do anything, we know what's going to happen, right? If we just give them pain control and send them home, we know that almost certainly they're going to end up with profound corporal fibrosis, erectile dysfunction. And then, gosh, Juan, you and I are going to be putting in a penile prosthesis on a case that we don't really want to, right? It's going to be really tough. And so for those guys, that's the conversation that I have. I say, yes, it's more invasive than a distal shunt, but it's not as disfiguring, right? Nothing's going through the glands. I'm retaining those distal glands caps. So in case you need a penile prosthesis long term, the chances of erosion of the implant through the distal caps are much lower, theoretically. And you might not even need the implant at all. I mean, wouldn't it be great? I mean, these are guys in their 30s and 40s, and we know that implants only last 10 to 12 years before they need to be replaced. And do I really want to be consigning a 35-year-old guy who borrowed his best friend's alprostadil on a bachelor party? Do I really want to consign that guy to 3, 4, 5 penile prosthesis surgeries over the course of his life? If I can give him a chance of erectile function recovery, I think it's worth the conversation.
Yeah, I love that. I mean, you gave the history and the data, the background, and put it together into what the discussion I also have with people in the hospital is. And the first part starts with hope, and that there's a chance. It's not high, but there's a chance. And I show them that exact multi-institutional study that you talked about. I show them the numbers, the possible erectile function recovery numbers for penoscrotal decompression compared to tunneling, compared to just a distal shunt, and say, look, the only way to find out is to give it time. Many of them aren't ready to make that commitment to have an implant. You know, they came in pain, they're suffering. They don't want to walk out of the hospital with something, permanent or long-term. And so it just allows us to have an ongoing conversation, be very involved. It's harder. You have to explain more and give more information. But I think one potential future area of study is going to be comparing satisfaction of patients who go through this process, have the opportunity of penoscrotal decompression, and whether they recover erectile function or not. What is their satisfaction? How do they feel when they if they ultimately end up needing a penile prosthesis?
Yeah, I'm glad you brought that up. And I'm glad you mentioned kind of the duress that these patients are under when they're in the emergency room. I think one of the hardest things about treating ischemic priapism is the fact that largely we're flying blind. We don't have beautiful level 1 high quality data to tell us what to do, right? We've got a number of key opinion leaders internationally who are trying a number of different things. But we have small studies with small numbers of patients, mostly retrospective. And so we don't really know what works and what doesn't. And as you mentioned, we are probably not going to get that nice level 1 evidence anytime soon, because those patients in the ER who are acutely uncomfortable from the pressure and acidosis of priapism are not really in a great place to consent to a randomized control trial, even if we, A, could design the proper trial, and B, could get enough sites nationally and internationally in order to accrue enough patients to really be able to say anything. That's the frustrating part about treating this problem.
Yeah. And like many other things in sexual medicine, it comes with, there's a component of taboo and fear and shame. And that recent, study we looked at of almost 200 patients at UCLA, by insurance, the groups that had the highest follow-up rates were commercial, privately insured, and Medicare patients. But even then, the highest number was just below 80%. So we know that when it translates from the emergency department to actually being seen in follow-up in clinic to talk about, well, what's next? How are you feeling? How are you doing? That many people are lost. And that number is much, much higher. Less than 40% of patients in California who had Medi-Cal, which is the state's version of Medicaid, the government state-based insurance, less than 40% had any follow-up, with the urologists who manage the priapism in the hospital. So we're losing people along the way. And so it's hard to collect this level of data.
Absolutely. Yeah, I think, in my own clinic, when I see priapism as the, reason for a new patient visit, I would say I probably have about a 50% hit rate of those patients actually walking in the door. And those patients have made the effort to make the appointment. Think about how many didn't even get that far. But there's so much taboo surrounding it, especially that same paper, your paper. We talked about ICI. The patients who came in with the longest duration priapism are the ones who didn't get injected in the office. They didn't self-inject with a prescription. They injected with ICI that they got from their neighbor or their friend or a guy off the street. And so they're that much more reluctant to come in. I mean, the average time to presentation was 30 hours for that group? There's so much taboo surrounding.
And so now we have our patient. We've been talking to them. They had a 24-hour, 26-hour, to make it easier, 26-hour priapism, and we're starting to think about the penoscrotal decompression. You gave a little bit of background on the corporotomy, but can you give us even a broader picture, that kind of step-by-step of the surgical planning? What's your approach? What's your technique once you're in the OR?
Yeah, absolutely. So once they are asleep, even if they're asleep, I start with a block. I tend to be block heavy for my patients. It's less anesthesia, less pain medicine that the patient has to have. I put a glands stitch in, a catheter in to help with urethral identification. And then I put the penis on stretch. If I have one available, I will use a Lone Star just because I'm a reconstructive urologist. We have them available. They are not necessary for this surgery. And then make either a transverse or a longitudinal penoscrotal incision. So right there at the junction between the penis and scrotum, you're going to dissect down through the dartos to Buck's fascia, overlying the urethra, clear out the tunica on either side, put stay stitches in to open up your area, or if you have medical students and residents with you, it's a great time for them to hold retractors. And then I put stay stitches in the same way I do for a penile prosthesis. So for me, that's pairs of 2O PDS. I like a CT2 because I think the needle shape is great for that corporotomy stitch. And then 15 blade to make a longitudinal incision in the corpora just past the tunica. You don't have to stab it in and stab the spongy tissue. You just got to go right through the tunica. And then you're going to squeeze the heck out of it in order to decompress a lot of that clotted blood. Now, the other part of the decompression is running a pediatric Yankauer or a dilator of your choice, both proximally and distally in the corpora, in order to disrupt that ischemic coagulum, that clotted blood that's in there. The proximal decompression is crucially important here because that's where the origin of the cavernosal arteries are. So we want to get close to nice and normal, and then you're going to see that beautiful bright red blood. Now, for people who don't do a lot of penile implant surgeries, what's important is to make sure that you are going lateral with your pediatric Yankauer when you're doing that dissection. So you're away from the urethra. Put the penis on stretch and just slide it. It's going to slide in. I pinky promise. And then I do the same thing on the other side. So when Al Morey first described this, he initially did it unilaterally with the thinking that you'd be able to decompress that clotted blood through the septum, right? And that worked well, about an 80% success rate. But there were 2 patients that failed a unilateral penoscrotal decompression and had to come back to have it done bilaterally. So we shifted over, and now I do this bilaterally in every patient just to make sure that we get all of that old blood out, relieve the compartment syndrome, relieve the pressure on that venous drainage complex, and then kind of reset the system with that nice, bright red blood. And then you close the corporotomies. And I'm sure you and I will talk a little bit about different ways that you can do this. I close my corporotomies watertight, the same way I do for a penile prosthesis. I do not typically leave a drain, but I will if I feel like I need to. I close them all the way. I run the dartos closed. I start running the skin closed. And then what happens some of the time? What do you see happen when you start closing the skin at this point? You ever see the priapism start to come back? You're starting to get that
woody edema. Yep, exactly.
Yeah. You get that reactive hyperemia, right? You get more inflow through those cavernous arteries. And so when you're rotating medical student is starting to close the skin, and all of a sudden you're at 40% erect, 50% erect, 60% erect. And then you say, oh gosh, what am I going to do? Right? And different people have talked about different methods to deal with this. Some people say, well, I'm just going to loosely tie the corporotomies so that some of that blood can still escape. And then I'm going to leave it drain, and I'm going to come back in a couple days and take it out. That works great. That's just fine. Right? With the understanding that those little holes in the corporotomies will seal up over time. What I tend to do is that I'm going to grab my injectable phenylephrine at that time, and I'm going to inject 200, 250 micrograms of phenylephrine while we're closing. Because when you think about it, we have kind of reset the priapism. You now have nice oxygenated blood in there. It's like you're reset to time 0. And so that phenylephrine should work. You inject the phenylephrine. It's going to cause smooth muscle contraction. It's going to relieve the pressure on the venous drainage system, and the guys come right down. So that's how I do it. I mummy wrap everybody. I keep the catheter overnight so that I can put a nice, tight, compressive dressing, and then I take it down the next morning.
Yeah, absolutely. That's very similar to how I've been approaching it. And actually, I've been doing the same phenylephrine trick ever since we talked about it at oral boards at dinner. And so at the end of every case, I already have the pre-measured phenylephrine from pharmacy waiting in the room to just give a little bit extra once we're getting to the closing stage. I have been leaving a drain, for urology Twitter, now X, used to be a lot more engaging and active a few years back. Dr. Alex Tatum had a fantastic set of picture steps, kind of very visual, step-by-step for the penoscrotal decompression. So I kind of have that saved on my phone, and I've shared it with residents or people who text me or call me from somewhere else who are planning to do their first or their second penoscrotal decompression. So the only difference would be that I have been doing the kind of looser tie of the corporotomies, reapproximated, but if I squeeze hard enough, just sitting there looking at it, it's not bleeding. But if I really grab the penis and squeeze it, you would see a little bit of a couple of drops of blood come through the corporotomy, and I'm okay with that. I'm happy with that. But knowing that if there's inflow of blood, hyperemia, a little bit of pressure builds and some blood does leak out, for that reason, I've been leaving a drain, usually about 3 days. If there's a lot of swelling, maybe up to 5, but I haven't had to leave it more than 3 days in the last couple of years.
I think that's totally fair. I think don't be afraid of the drain. And if you're really nervous about that reactive hyperemia and recurrence, I think leaving the corporotomy sutures a little bit looser is just fine. I agree. I really like that pictorial walkthrough that Alex Tatum has. We also published a video on this, I think 2 years ago in VJSM. So if anyone is interested in a walkthrough, you can see step by step how we manage this there as well.
Yeah, that's probably an underutilized resource. The videos on VJSM are fantastic, and they go everywhere from, priapism to prosthetics to Peyronie's, and now more scrotal surgery, and even infertility I've been seeing recently. Immediate post-op care. You talked about immediate post-op care. You talked about the leaving the Foley in till the next day. I do the same thing, taking down the wrap, letting them have a trial of void. Is there anything else that you do in terms of duration of antibiotics or things, before they leave the hospital and as they're transitioning to that outpatient follow-up?
Yeah, I don't typically prescribe antibiotics for these guys. I worry a little bit more on the guys who have had, one or multiple distal shunts, have had, they've become pin cushions in the emergency department. But for the most part, I don't prophylactically prescribe a lot of antibiotics. In my practice, I wait and see how they do. One thing that has been described, Tom Liu actually described this, was this theory that recurrent priapism may be due to, a thrombotic event of kind of occluding of the shunt that you make, that, he described it with distal shunting, but I'm sure it holds through in penoscrotal decompression as well. And so I know Jeff Lodoyle had mentioned when I talked to him about this, that he will put people, I think, on 5 days of a baby aspirin. I think Tom Liu has actually talked about being a little bit more aggressive and sending some patients home with Plavix. I have not done that in my practice, not saying I won't try it at some point, but it's not something that I routinely do. What about you?
No, same. Yeah, don't do antibiotics unless they've had like multiple. There's the rare guy who's had not only several days of intermittent aspiration, irrigation, phenol, but they've had a distal shunt, and then they went somewhere else and had a distal shunt with tunneling, and now they're here. That person, I may provide just a few days of antibiotics, especially if on exam there's, more erythema than expected. But in general, exactly right. No antibiotics. Just wait to see how they do. I haven't done the aspirin or Plavix or anything either. I've thought about it for the distal shunts because of, Dr. Liu's lecture, and the mechanism that he describes behind it makes perfect sense. I just don't know. We don't know enough about the physiology, what's going on within the corpora, to know if without a intentional shunting to, the glands, if we would have that same benefit in penoscrotal decompression.
Yeah, I agree. Now, do you do anything else? Do you send your guys home on PDE5 inhibitors? Do you do pentox? What have you tried in your practice?
Yeah, no. So I think the next step is probably the most critical, and I'm sure you agree that it's time for rehab. And just like we do it in prostate cancer survivorship and other areas of sexual medicine, we want to try and offer everything possible to optimize their chance of erectile function recovery and try to get a signal as to whether there's going to be any kind of recovery or turning on of the corporal tissue. And so I do use PDE5 inhibitors. Essentially, as soon as the drain comes out, I start them on at least a low dose daily Cialis. If they had any previous erectile dysfunction history, I'll even start at 10 milligrams daily. There was a nice review from Dr. Carrion and the team from Florida that also talked about the potential benefit of pentoxifylline and kind of using it similar to how we use tadalafil and pentox in Peyronie's disease and trying to prevent further fibrosis. So I've been adding that to my regimen, 400 milligrams BID, because most guys just don't like taking TID medications. And then vacuum pump. I think the vacuum erection device is such a critical component, not only for seeing what the erectile function recovery is going to be, but the scary part of the prolonged priapism is preventing the loss of length. I think it was Dr. Bruce Cava's study from a couple years back that, whether you explant an implant or if it's a prolonged ischemic priapism, that there can be an average length loss of up to 3.7 centimeters, if I'm remembering the exact number. And so using that vacuum device early on to preserve penile length, preserve girth, and just make sure that we don't run into that situation where we're, drilling through concrete in the OR to put in an implant.
Yeah, I agree. I think the cornerstone of recovery is the vacuum device, and having them do it. I tell them, as the more you do it, the more effective it's going to be, right? I want you to do it at least twice a day for at least 10 minutes. But really, a 20, 30 minute use of a vacuum erection device is much more likely to inhibit that fibroblast ingrowth and development of that corporal fibrosis, because you're right. What we don't want is to be dealing with this in the OR when we go to come back and put in an implant.
And that's what affects patient satisfaction too, right? If they're going to end up going down that way, the reason the guidelines talk about early penile prosthesis placement, outside of the context of PSD versus delayed, is that for those delayed cases, patients have gone now more than 6 months since their priapism. The satisfaction rates, I believe, dropped from about 90 to 60%, significantly lower. And there was a lot more fibrosis, a lot more scar tissue, smaller penile size, penile length, and then in many cases even having to use kind of narrow base cylinders or the narrower cylinders for the two different types of implants just to get something into the body and give them a fighting chance.
Yeah, and they specifically mentioned that the primary driver of lower patient satisfaction was the length. So I don't know if you do this. This is a tip that I learned from Steve Hudak when I was in my fellowship, is to get patient buy-in, right? So most of these vacuum pumps are clear. So I now tell my patients, get a big old Sharpie, and the first time you use your vacuum pump, mark with the Sharpie where your penile length is. And then as you're going through this rehab process, you can keep an eye on it and see how things are going. And you can say, okay, am I losing length? And sometimes I think when they see that they're losing length, they kind of jump on the bandwagon a little bit more and they start to be a little bit more aggressive with their VED protocol. Or am I gaining length? And even if they don't, you can tell them that, by the time you make it to the OR for your penile prosthesis, you've done everything in your power as the patient to make the surgery go as smoothly as possible and to maintain as much penile length and girth as possible. So I really like getting the patient buy-in from that aspect of things.
Yeah, no, that's so critical. I'm going to take one step back. We talked about this offline, but I think it'll be important for other people to hear it. The other thing I've been doing for that patient buy-in, but also just counseling, is I've been taking corporal biopsies in the OR at the time of the penoscrotal decompression. Tiny amount of tissue, just a little bit of corpora that's right there when we're making the corporotomy. Grab it with a DeBakey and just take meds and cut whatever's below the tip of the DeBakey and send that off. because in a couple of the more prolonged cases, already at the very beginning of that case, before I did anything, the pathologists were able to comment and say that there was already corporal necrosis or early signs of necrosis or just completely necrotic tissue. And I think that makes it easier to have the conversation. It's a little, objective thing that somebody looked at under the microscope. And I wonder over time, I'm hoping to be able to look back and see whether, those biopsies correlate with erectile function recovery, or is it hit or miss? Is it, is there still a chance no matter what?
Yeah, I think it's such an interesting research question, right? Because we don't know. It's kind of the same thinking that David Ralph has with getting the MRIs, looking for necrosis in the tissue to use that for patient counseling and try and see who might do better with an upfront prosthesis when they come in with priapism. But the real answer is we don't know, right? We don't know how much that correlates to erectile function recovery. How many of these guys who get, a distal shunt with tunneling or who get a penoscrotal decompression who have that smooth muscle necrosis, how many of them do go on to long-term severe ED and how many of them see some recovery? And we just don't know. So we got to do the study.
Yeah, that's exactly right. Another concept to keep in mind here is, and the reason that I've really shifted towards offering the penoscrotal decompression in the acute setting in the hospital for these prolonged priapisms, certainly more than 24 hours, is that yes, again, that hope component, we have a chance, but not over-treating. And meaning that if I threw in a malleable in every person that came in and they had a 24, 36, 48, 72, some of that early, including that multi-institutional study data, penoscrotal decompression did show with prolonged cases having some erectile function recovery. So I think it's mutually beneficial. I want to make sure I'm not over-treating, and at the same time, it allows patients and people time to process, to come to the decision together. And if there's not recovery of erectile function, then feeling the buy-in on both sides of, okay, really our only option now is the implant. And so there's a little bit more of a sigh of relief when making that decision, as opposed to in the acute setting of pain and all the craziness that surrounds an acute ischemic priapism episode.
Yeah, absolutely. And, as much as the next guy, I would much rather put in an implant before all that corporal fibrosis sets in. If you give me a choice, that's what I'm going to choose so I can, get on to the next case. But we do have, as you mentioned, a lot of ways to help us successfully get implants in the hostile penis. We've got cavernotomes, we've got vacuum therapy, we've got narrow-based implants, we've got malleables, we've got lots of options that make it much more successful and much more feasible to get implants in these guys, if necessary, long-term, than we had, 10 years ago. So I'm with you. I don't want to over-treat a guy if there's a chance that he might recover erectile function on his own.
And for the, we're talking about rehab, there's a lack of data. So it's a little bit of vibes and giving things time and just setting up a follow-up schedule, what works for you, your practice, your system. How long are you waiting when people have undergone a penoscrotal decompression? You're on these regimens or using the vacuum device. Are you saving a time for the OR 6 weeks later? Are you giving it 2 or 3 months? What's been your average timeline, knowing it's going to vary person to person, insurance issues, et cetera?
Yeah, I think the variance person to person can't be overstated, right? It's going to be a little bit different for the guy who came in with a 72-hour priapism versus a 24, or the guys who've been up for a week before they come in. But on average, I'm probably not going back before 3 to 6 months for a lot of these guys. I'm going to give them a chance to recover. And that's what we saw in that survey study, is that most respondents said that they would go back in that 3 to 6 month time frame to put an implant in. And some of that is OR availability. I don't know when you're booking cases, but, most of us are booking cases a couple months out. Some of it's insurance, and some of it is, maybe the patient just isn't quite ready, either physically or mentally, to take that next step.
No, yeah, that's critical. And that's why I wanted to highlight it to our listeners, because if you go and read in the priapism guidelines and the idea of the early versus delayed implant, some of the early implant definitions are as quickly as, 6 to 8 weeks. And I do think you buy some time if you have the opportunity to have that follow-up, to have the dedicated, teamwork approach. We're using a vacuum pump. We're doing all these other things. You can stretch out that timeline and still get a good result, still get in a good size implant, preserve length. It's going to be crunchy. You got to have all the right equipment in the room. You got to have the cavernotomes and be ready to troubleshoot. But I've been doing about the same, probably closer to the 3-month range, certainly within 6 months. Well, Maia, this has been a fantastic discussion, something that I've been looking forward to doing for quite a while in a more formal setting instead of just over a dinner and a glass of wine. So I think if I could summarize a lot of the key points of our discussion today, in terms of priapism itself, obviously early recognition and escalation are critical. And we have guidelines, we have a pathway on how to move forward, how to best treat these patients, but the urgency and the emergent nature of the situation can't be underestimated. And beyond the aspiration, phenylephrine, the non-surgical options, we have surgical techniques that have to be utilized and used. But I think it's okay to lean in on folks in the community, in your region, in your area, who might have, kind of these centers of excellence or areas of expertise. And if someone's not responding to a distal shunt, being able to communicate, connect with colleagues within the world of urology and refer folks to get these additional next steps, or certainly the follow-up after a priapism. To me, penoscrotal decompression offers an effective alternative to traditional shunting, and particularly for the prolonged ischemic priapism, like you mentioned, after those 24 hours. And many times I'll go straight to that to preserve the glands and preserve the corporal tissue. And throughout this whole process, in the hospital, after the hospital, and beyond, the patient counseling component is so essential, because no matter how technically beautiful and perfect things are, the priapism itself can lead to permanent erectile dysfunction, and that just has to be reiterated.
Absolutely.
Maia, do you have any pearls, anything else that we haven't touched upon or haven't talked about yet that you want to leave our listeners with?
So I think if there's something that I want our listeners to take away, it's the fact that even though you and I, Juan, are subspecialty urologists, priapism is not a subspecialty urology problem, right? It's a general urology problem. And I don't want our listeners to hear us talking about this and think that they need to be referring or transferring in all of these patients with ischemic priapism to big tertiary care hospitals to get this surgery done. Because the fact of the matter is, anyone can do this problem. Any urologist can do this surgery, right? You don't need special equipment. You don't need a Lone Star. You don't need special dilators. Those things are helpful if you have them, but they're not necessary. So get the gland stitch in, get a catheter in, put the penis on stretch, and the anatomy's right there for you. And when you think about it, it's not that different than the incision that you make for a proximal penile fracture or a proximal penile gunshot wound. And those things might come in when you're on call as well. This is not that different than that. And so this is definitely a surgery that can be done by anyone. And as you mentioned, there are a lot of us around, who are on social media, or you can reach out to us by email. We're happy to share our phone numbers, that we are happy to talk about this real time to walk you through, one, whether it might be a good fit for your patient, and two, to really give you some of these tips and tricks to walk you through the surgery. I know I'm happy to do that anytime.
Same. If I could, put my phone number and email out there for everyone in California to reach me, I 100% would. And some of that will be available in the show notes so that people can contact if they have questions or they want to just talk through. I've already done it with some of the local community urologists that I've gone to meet over the last several years here in LA. But yeah, my email, my phone is always open to talk about these cases. Well, with that, folks, listeners, thank you for tuning in. It's been a great conversation. I hope this was helpful. I listened to BackTable Urology as I was prepping for both written and oral boards, so we wanted to focus a little bit on the guideline component as well. But there are new things coming down the pipeline, and we're hoping that we can improve the care for patients with priapism.
Yeah, it's been a real pleasure to be here. Thanks for having me.
Thanks for joining us.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio.
And Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.